really a privilege and honor to be here and speaking to a huge gathering in this hall. This is not a kind of research talk. It is more of basic talk, how to manage resistant hypertension. And she was a known case of hypertension since last 15 years, and blood pressure was controlled with 3 anti-hypertensive drugs. On further inquiry, it was found that she had 4 pregnancies, all of which were plagued with episodes of uncontrolled hypertension. Each time it was managed with IV letrozole and hydrazine. Her first 3 pregnancies went through with difficulty, but she lost the twin pregnancy the 4th time. Both the babies in her belly expired. And now the patient's workup was started. And her basic investigations, fundoscopy revealed hypertensive changes. She was hypertensive for the last 15 years. The rest of the initial examination and labs were unremarkable and included RFT, that serum electrolytes, Doppler of kidneys, urinalysis, urine for BMA, aldosterone renin ratios, thyroid function. ECG and echo done in ER showed that she had an LVH, and the ejection fraction was more than 65%. She was taking atenolol, amlodipine, valsartan, and hydrochloroquine. So she was discharged from the ER on an oral 4 antihypertensives and labeled resistant hypertension. The patient presented in the OPD to a nephrologist for the second opinion, and her blood pressure was still recorded at 200/100. Now this nephrologist checked her blood pressure in the lower limb, and he found that the blood pressure was 130/90 in the right leg. So he asked for, this echo had already been done, so he asked for a CT audiogram and a coronary angiogram. And this is the, as you can see, angiogram. These are the enlarged intercostal right internal memory and left internal memory arteries. The report showed that there was a coarctation of aorta after the left subclavian, and the aortic segment before was 12.5, at the level of coarctation was 4.4, and after the coarctation was 16 millimeters. She had both dilated right and left internal memories and intercostal vessels which were prominent. As you can see, there is a coarctation present there. So she was successfully stented by an aortic stent, and her blood pressure stabilized, which was in the range of 200s in the past. Now you see, this is a lady, young woman, who was in all 15 years, 4 times became pregnant. She had a blood pressure every time shooting up. She was on antihypertensives. And nobody ever checked blood pressure in the lower limb, except for a nephrologist who checked it after 15 years. Luckily, in these 15 years, her kidney function was still safe. So that is the importance of labeling a patient resistant hypertension and not looking at the cause of hypertension. So from that I move on to the basic definitions. You're all familiar: normal, elevated, high blood pressure, and hypertensive crisis when the blood pressure is more than 180/120. So blood pressure, as defined by the EHA guidelines, is that it remains resistant hypertension when it remains above the goal in spite of 3 concurrent antihypertensive agents of different class, and out of which one should be a diuretic. And then the patient is controlled with 4 or more drugs and is considered a resistant hypertension. But there are certain assessment requirements before you label that patient resistant. That is, you confirm the accuracy of blood pressure out of office measurements, and you confirm adherence to a healthy lifestyle, and you confirm discontinuation of substances that can increase blood pressure, and recognize and address the hypervolemic state that may be not enough to produce edema, but it may still be there. And consider the evaluation for secondary causes if it is highly suspected. So the resistant hypertension is not that uncommon. 2 to 42% people may have, it's quite variable because of various ethnic and geographic variability. And in a general population, it could be estimated to be about 10%. And the NIHAN's data showed 11.8% resistant hypertension. All had trials showed 12.7% resistant hypertension. And this big study, 468,000 patients, 32% were having resistant hypertension, but they were not prescribed optimal treatment. So in comparison with hypertension patients, if you look at these resistant hypertension patients, 48% had diabetes as compared to those with controlled blood pressure, and 45% had CKD, or 41% had ISD and cardiovascular disease, cerebrovascular disease, and 16%. So that shows that there are greater chances of having these problems if you have once diagnosed with resistant hypertension. And this increases the risk of target organ damage. The CRIC study, the chronic renal insufficiency study, showed cardiovascular 38 and renal 28 risk. But when they looked at the other multivariable things, the men in the black race, the larger waist circumference, diabetes, MI, stroke, all these were strongly associated with the resistant hypertension. But as nephrologists, when we look at resistant hypertension, we see that what is the link with the GFR. So as the GFR falls to below 45, the risk is more than 33%. And it is also directly correlated to the albumin-creatinine ratio. The higher the ratio, the higher is the risk of having resistant hypertension. So this is a list of medicines which are used and which can increase the blood pressure. And amongst these, we cannot forget calcineurin inhibitors, erythropoietin, the use of steroids, NSAIDs, etc. And certain stimulants and sympathomimetic agents. Only last week I found a patient came with very high blood pressure. He was taking 4 drugs and he said, my blood pressure is not controlled. The only thing he mentioned, I've got a severe allergic rhinitis, and I take every hour I take nasal drops and sprays to keep my nose patent. So that was a huge amount of nasal decongestant he was using, which was not allowing his blood pressure to be controlled. Certain habit-forming drugs. And then once we talk about resistant hypertension, we must rule out renal artery stenosis as a nephrologist, because unless there is proteinuria or there is increase in creatinine, a physician would not refer a case of resistant hypertension to you, because they don't consider mostly renal artery stenosis. It's only the nephrologists who think about it seriously more than other people. Obstructive sleep apnea syndrome is also a relatively less suspected disease. Many a times it is this which, if you correct obstructive sleep apnea, resistant hypertension goes away. High endo-renin ratios, Cushing's, mineralocorticoid excess, Liddle syndrome, which is excessive epithelial sodium channel ENaC activity causing increased sodium absorption, or Gordon syndrome, which is basically type 2 hypoadrenalism or adrenalism, leading to Gordon syndrome. And there is pheochromocytoma, thyroid disorder, and the last one I just described the case to you, who was undiagnosed for 15 years. So there is a stepwise approach to resistant hypertension. If the patient is on more than 3 drugs, well, you have to make sure that the blood pressure readings are accurate. And then you ask for lifestyle modification. And you look at the compliance. And drugs which raise the blood pressure, you must exclude. And you may add a diuretic and look for secondary causes. If this is not there, you go back to ambulatory blood pressure monitoring. And if lifestyle modification is not helping, ensure salt intake to be a major factor. Only a few years ago, in the American Society of Hypertension meeting in the US, the president of the American Society of Hypertension presented a case. It was referred to him as resistant hypertension. And he admitted the patient and looked at the urinary sodium. And a patient who was on 5 drugs, after salt was excluded from the diet, his blood pressure came down to normal. And from 5 drugs, the patient came down to 1 drug for the control of blood pressure. So I think the salt intake part is still underlooked or overlooked as a cause, because this case was presented by the president of the American Society of Hypertension, USA. We have to look at that the drugs the patient is taking, they are optimized, diuretic is added, and if this doesn't happen, to work up for secondary hypertension. So, what is the treatment of resistant hypertension? You stop the medications that raise the blood pressure, identify secondary hypertension, and look at the out-of-office blood pressure monitoring to exclude white coat hypertension. And now ambulatory blood pressure monitoring is a very useful tool. So there is a non-pharmacological therapy, there is a pharmacological therapy, and there are certain interventions. The ambulatory blood pressure monitoring, patients, you can divide them into 4 kind of patients with ambulatory blood pressure readings. And if you look at if the daytime blood pressure at ambulatory blood pressure monitoring is less than 135/85, or nighttime is less than 120/70, it's called controlled hypertension. And if it is masked hypertension, when it is high, but with the doctor it is not there. Or true hypertension when it is high at home and also recorded in the office. And then white coat hypertension when it is high in the office but normal at home. So what do you do if it is well controlled? Well, you repeat the ambulatory blood pressure monitoring yearly. If it is one of these situations, you intensify the treatment, or you may add an aldosterone antagonist or add a bedtime antihypertensive and repeat the ambulatory blood pressure monitoring after every intervention that you do. If it is white coat, if it is true hypertension, you again intensify. If it is white coat hypertension, then you look at the systolic blood pressure. If it is more than 15 or 115 or daytime less than 115, you may repeat it 6 monthly or yearly. So lifestyle modifications for resistant hypertension, for any hypertension. There is hardly any money in disease prevention. Most of the people go for surgery, pills, reduce blood pressure. Weight loss, healthy diet, reduced intake of sodium, enhanced intake of potassium, all these have significant effects on the blood pressure. You can see these, even in the normotensive people, these changes do take place. Physical activity, aerobic, dynamic or isometric exercises, they reduce the blood pressure significantly. And weight loss, as you will see, is linked for every 1 millimeter drop, and you expect 1 kg reduction in the weight loss. So if somebody loses 10 kg, his systolic blood pressure will come down by 10. So what should be the choice of regimen for resistant hypertension? Well, of course, you have to individualize the treatment according to the, as Dr. Lara's theory R hypertension and B hypertension. He says that there are only two types of hypertension, the renin-mediated and volume-mediated. So he calls them R hypertension and B hypertension. So the drug of choice are mostly ACE inhibitors. They are being, as most of the guidelines indicate, or calcium channel blockers or a long-acting thyroid diuretic. And if the blood pressure is still uncontrolled, you may consider to add spironolactone and titrate to 50. But of course, it is difficult in CKD patients to do that because of the risk of hyperkalemia. And still, if it is not controlled, then you may add a beta blocker or labetalol or centrally acting or vasodilators to this. Now, typically the volume expansion, which is part of the resistant hypertension, is typically not sufficient to produce edema, and that is why the BNP levels, which are higher in patients with resistant hypertension, when you add a diuretic, it gets better. But for people with GFR which is less than 30, you may need to use a loop diuretic like most of the CKD patients. Apart from metolazone, which acts better even with chronic renal insufficiency. And this I have already talked about. Then certain interventions, the renal denervation, barrel receptor, barrel reflex activation, carotid body ablation, and renal artery stenting. All these, this is the simplicity catheter to denervate the renal vessels and therefore cause reduction in the blood pressure. It acts through various mechanisms, by natriuresis, by reducing the norepinephrine release, and by lowering the renin activity and increasing the afferent signaling to the sympathetic activation. And then the Rios device, which is basically to stimulate the baroreceptors, may be useful in patients who cannot take medication. And then central arterial venous anastomosis, which has, you can see that before the procedure, blood pressure, systolic and diastolic, and reduction, which is found statistically significant, but there are risks of venous stenosis. From that, I move on to the hypertensive emergencies. And again, hypertensive emergencies, we divide them into two. The hypertension E and hypertension U. Hypertension E is when the blood pressure is raised more than 180/100, but there is evidence of end organ damage going on. And people urgency when there is no end organ damage. So basically, this is a severe and abrupt increase in blood pressure, which is impeding the progressive end organ damage, impending end organ damage. And patients with hypertension E, they require hospitalization and prompt treatment and close monitoring. And patients with hypertension U can be safely managed in OPD, without, if they have target organ damage already like LVH or CKD, then you have to deal with them differently. So here I talk about a few cases. Let's say there are 5 patients who come to you. All of them have a blood pressure more than 180/120. Patient A has nausea, vomiting and confusion. B is short of breath, spitting sputum, pink sputum, and having chest pain. Patient C is having sharp tearing, chest pain and back pain. And patient D is one with 6 hours history of right-sided weakness. And patient E has headache and is concerned about his hypertension. So we look at these different scenarios in patients with 180 or 120 who fall in the hypertensive urgency or in the emergency. So this patient, first patient, is actually having hypertensive encephalopathy because he has confusion and there is a presentation of end organ damage, and cerebral autoregulation is overwhelmed and is leading to vasodilatation, edema, and increased intracranial pressure. The patient can even have seizures. So it presents with headache, visual changes. So the drug of choice with such a patient would be IV labetalol in the form of a bolus. And the target is to reduce the mean arterial pressure not more than 20 to 25% in the first 2 to 8 hours. But vasodilators like sodium nitroprusside or hydralazine, they have a risk of producing intracranial shunting. The second patient is a patient with pink sputum and chest pain, and he has acute pulmonary edema, and this type of patient has gallop and crackles, and these patients require urgent treatment, and of course these patients may be treated with nitroglycerin infusion or with levetiraol if they are not in failure, or with enalapril or sublingual captopril. And again, the target is to reduce the mean arterial pressure by 20 to 25%. The third patient who had pain relating to the back, tearing type of pain, has aortic dissection, and this dissection requires urgent treatment. And of course, the drug of choice in this situation is nitroprusside or esmolol or levetiraol, and hydralazine is contraindicated in this kind of situation, cause reflex tachycardia. The last patient, the fourth patient, is having a CVA because he has weakness of right side. And both in embolic and hemorrhagic stroke, it is essential to maintain the adequate cellular blood flow. And if it is embolic, you try to bring it down from 220 to 100. And if it is a hemorrhagic stroke, then you bring it down to less than 180 or 105, and not lower it too low. Patient E has mild headache, and there is evidence of no evidence of end organ damage. He is just concerned he can be managed in the OPD. Because these chronically hypertensive patients can tolerate the mean arterial pressure better. So, if we look at these factors, which one do you think is the primary reason for hypertensive emergencies? It is mostly non-adherence to the treatment, which is the cause, and we must ensure patients make false statements. Blood pressure goals of hypertensive emergency: the first hour reduced by 25%, 2 to 6 hours reduced to 160 or 100, 110, in 6 to 24 hours 160 to 110, and in 24 to 48 hours goals according to the guidelines. So various oral drugs you can use in hypertensive emergencies is captopril, clonidine, and levetiraol. Doses and durations are mentioned. But if it is a pregnant woman with high blood pressure, you can use levetiraol or you can use hydralazine. But you have to keep in mind lupus syndrome with hydralazine. Nitroglycerin is typically used for patients with LVF, with coronary ischemia infarction. Sodium nitroprusside for increased, again when you rapidly need to lower the blood pressure in many situations. And then esmolol, metoprolol, levetiraol, more or less similar indications, enalapril for left ventricular failure. And these are the kind of doses, the onset of duration. I would like to mention phenoldiprine, which is for renal physicians. It is a highly selective dopamine 1 receptor agonist, and it has 10 times more potency for dopamine than dopamine as a renal vasodilator. And its antihypertensive effect is by natriuresis and vasodilatory effects, and it is agent of choice in hypertension emergencies associated with renal dysfunction. And it should not be used for contrast-induced nephropathy. The use of sublingual Nifedipine has been discouraged because its absorption is erratic. 20 years from now, we used to give sublingual drops of Nifedipine to control blood pressure in the ER, but it's no more available. And because it lacks documentation, and if you lower the blood pressure too rapidly, patient can collapse. So, in hypertensive crisis, this is my last slide, look for presence or absence of target organ damage based on the presenting complaints, physical findings and the labs. The goal is to reduce the blood pressure not more than 25% in first hour, and there are specific drugs for specific situations. And the goal of medication basically is to provide smooth reductions in the blood pressure, optimize blood pressure values with readily titratable agents while avoiding complications and adverse effects. Thank you very much.